Jeff, what's that picture behind you?
Oh, that's some NYPD SU trucks. I
Oh,
was doing
okay.
some training
Now I
out
can
of
see it
Floyd
better.
Bennett Field with them. Yeah.
I couldn't see it when you were in the small view.
Yeah.
Yeah, now I can see it. That's good. It's a perfect picture.
Yeah,
Blue
they
sky.
set it up. They were doing some demo out there, so they had it all set up for photos.
Excellent. Okay, it's 9:30. I'm going to bring the meeting to order. Bill, would you like to do a roll call, and then we'll make sure we have a quorum and we can start.
You're on mute if you're speaking.
This might be why no one's answering me. Dr. Murphy?
Yeah, I'm here.
Okay, Dr. Papish? Dr. Arshad? Dr. Larson? Dr. Stu Miller?
I am here.
Dr. Brutus? Dr. Cosard? Dr. McGinley? Dr. Mao?
I'm here.
Dr. Chung? Dr. Natobis? Dr. Midori? Dr. Struble? Dr. Templeton? Dr. Sabia? Dr. Greenhack? Dr. May?
Here.
Dr. D. Thomas?
Here.
Dr. Brutus? Dr. Brock? Dr. Cohen?
Here.
Dr. Santos? Dr. Kakuza? Dr. Quintero? Okay, just give me a minute. I think I saw Dr. Papish.
Here.
This is Larson on the phone.
Okay, thank you. Is there,
Anyone else on the phone that he didn't read your name off that we get you on the attendance sheet?
Ray Bridge, I'm here.
okay, yes, I got it. Thank you. We are one physician short,
Okay,
so we need one more.
so what we'll do is we'll hold the minutes until one more person shows up. It seems like there's a lot of people on. How many do you have counted down? Because we have 21 participants. 1,
7.
4, 5, 6, 7. Okay. All right. So what I'll do is I'll table the minutes until we get one more person on board. Looking at, good morning, everybody. Thank you for coming and thank you for participating. So we have old business here. As you know, we've been working through the supraglottic pilot program. And actually it was funny because at REMAC I don't know when it was, 2 weeks ago. They said, so Pam, how's it going? And I said, well, it hasn't left the commissioner's desk. So until it leaves that desk, it's not going anywhere. But I did explain to them that many more agencies have reached out, even from Long Island. So we will have a great participation, and it'll end up being quite a few agencies, so that we should be able to meet some good numbers and have a decent setup. So hopefully the hint was there to push it along. So I'm hoping that it does. It did bring up, and through the conversation at CMAC, it did bring up the question of, should we have a medical director on the EMS board? Because, you know, as you know, there really is no medical director there. And it would be nice, I think, if we had someone that would be able to push these things through and keep track of them. Because everybody's busy, everybody has so much to do, but a medical person, a true ED physician, would be looking at these things and to get them to fruition, because they impact clinical care. SLAM's update, anything, Michael?
I just interrupt you for 1 minute. Dr. Arshad has come on board, so we do have a quorum.
Okay, great.
Oh, Dr. Papish, have you had any communications with Dr. Berkowitz or anybody at Westchester with regards to the education and training?
no, we got to jump on this because it's getting late. The planned rollout was January, and we're behind the 8 ball a little bit. The last meeting that we had, we said we were going to get together this past month, and everybody's been busy. So we'll plan on getting this done in November, hopefully, so that we can roll everything out beginning in January.
And you have the whole training protocol and the whole setup. So it should be very quick as soon as that happens.
Yeah, I mean, it's set up conceptually.
Yeah, we just have to physically, yeah. Okay,
Right.
great. Thank you, Mark. Now that we have a quorum, I'd like to bring back to the minutes from the last meeting. Karen distributed them in your packet. I didn't see any glaring, corrections to be made or any additions or deletions. If anyone has anything, please tell me. Or otherwise, I'll ask for a motion to accept.
Motion to approve, it's Dennis.
Thank you. A second?
Second, Stu Miller.
Thank you. Appreciate it, David. Okay, moving along, service upgrades. So, Bill, why don't we allow Port Jervis to speak now?
Okay, we can do that.
So just you give a little introduction to our colleagues, and then they can present their case.
We have Port Jervis is here in the office now. They'll introduce themselves, and they're submitting. They have submitted an application for AEMT to serve the Port Jervis area. We've had a lot of issues with ALS out there, and they don't get ALS very frequently. So this is their effort to advance the care to the patients within the Port Jervis community. At this point, I'll turn it over to George Ewing, who is the chief operating officer at Port Jervis Ambulance.
Okay, sorry, it's a little awkward talking to a wall. In the coming years, I mean, obviously, everybody knows Port Jervis did have ALS once before, and due to a number of different issues, the ALS had to be shut down. Nowadays, since Port Jervis has reopened, because back in 2016, there was financial issues, Port Jervis had to close, we had to reopen. Since we reopened, the organization is extremely financially sound. Every single one of our decisions is made with a lot of research and involvement behind it to make sure that we're not making, for lack of a better way to say it, stupid decisions. Given the current rate of pay for paramedics in the Hudson Valley, Port Jervis Ambulance obviously cannot keep up with the rate of pay for paramedics. our demographic is just not there. I mean, any commercial service can tell you our demographic, it's a hindrance, and that's why we don't get, that's why we have no ALS station out by us, things like that. AEMT is a perfect opportunity for us. Not only one, does it give us the opportunity to promote from within because it's a 4-month-long course versus a 18-month-long paramedic course, but it also is more intriguing to our volunteer personnel as well because it's a 4-month-long course versus an 18-month-long course. Our medical director, unfortunately, he couldn't be here. He had to work today. Dr. Keith Hartnell is very excited about this program. We've laid out a plan where over the next 12 to 18 months, we will have full AEMT coverage on almost every ambulance that rolls out the door for Port Jervis. Fortunately, I have a lot of friends that like to do me favors. And until we have 100% AEMT coverage, I have a lot of paramedics that are going to come on board and offer their services as AEMTs in the interim. I currently have 2 full-time AEMTs on staff, myself being one. I have a part-time paramedic on staff, and we just brought on 6 additional per diem and part-time paramedics, as well as I have 2 paramedics that are volunteers on our roster as well. That makes a total of 11 providers that we have at the current moment. I'm going to currently recruit more people as we can go along, but not only that, the cost involvement of AEMT versus starting up a paramedic program is significantly cheaper. We did the actual research on this. The cost, aside from a 12-lead monitor, the cost involvement to set up a set of AEMT gear just to roll out the door is roughly about $1,500 versus your average of $5,000 to $6,000 for a paramedic set of gear. So these are all the things, like I said, we've done the research. We see ALS less than 10% of the time. And I apologize if it seems like I'm rambling a little bit, kind of, but we see ALS less than 10% of the time in Port Jervis. And we are an agency that's doing, right now at this current moment, we've done 3,500 jobs just this year alone. So we're looking at over 4,000 jobs this year. And we see ALS less than 10% of that time. Don't get me wrong, I'm not trying to knock our ALS vendors one bit whatsoever. I mean, they have to do what's financially sound for them, and I completely and wholeheartedly agree with that. But this is what my board has agreed is the most financially responsible thing for us to do for our patients. This is something that we can afford. We've already gone through and the equipment is in-house. We've already applied for upgrade as well in Pennsylvania. We should actually be getting inspected by Pennsylvania sometime this week and be going live with Pennsylvania probably by the end of the week. We're also establishing our own training center in Pennsylvania so we can continue to train more EMTs, AEMTs, and even CFRs in the future.
Good, just give me a minute. Just so everybody is aware, Port Jervis is certified in Pennsylvania also and does supply service there. They're on the border. Port Jervis is on the border of Pennsylvania, and they do have the dual certification, and they've had that for many years.
Mm-hmm. Now I lost my train of thought. So as far as that goes, I mean, one of the things that's been so great about Port Jervis over the years is that our providers come to us because we are so busy. Our providers come to us because they get a real education in how to provide patient care. I'm not saying that nobody else does this, but we take it very seriously at Port Jervis. And our providers that our students even ride along with take it as a very serious responsibility to make sure the students are trained well and on top of it. When I went recruiting paramedics for us to get this AEMT program off the ground, I made sure that these were paramedics that our AEMT students that are starting class within the next few weeks are going to be able to ride with. They're going to be sound providers by the time they're done with class. I apologize. Like I said, I really didn't expect to. Yeah. Anyway. as far as that goes, like I said, we're on track. This program is set up. We're ready to go. I would be more than welcome to field any questions at this point.
So I think the only thing we had initially was, and you know, a bunch of the members of the committee are on the phone, on the Zoom call, was the 24/7. So if you solve that, George, I don't see anything else holding up your application. The one thing, so that everybody knows, this will be our first AEMT program. And so it's a process they use quite a bit upstate. The Remo region, many regions use it, but this will be our first one. Any comments, any questions for George? That sounds like a no, George.
Oh, I wasn't sure if anyone was typing. The one other thing that I'd like to add, I'll tell you right now, Jeff can attest to this. I'm really big into the research and the computer and the geeky data collection part of EMS, and I work very closely with Jeff when it comes to data collection for EPCRs. And I just want everybody to know that Port Jervis has no problem working with the region on doing all the research on the effectiveness of this program. What can we do to make things better? What can we do to change things? That's a very big thing for me moving forward, because I mean, I've been doing this for 23 years, and the only thing I want to do is improve the level of service. So.
Okay. Well, appreciate your time and appreciate you coming. And so what we'll do is we'll offline meet and go forward with all the stuff we need, and we'll get back in touch with you, George.
Okay, thank you very much.
Sure.
She's there.
Okay, following along.
Just a quick question.
Sure.
So just to verify, then you are ready out of the gate to do 24/7.
Oh, I could start 24/7 tomorrow morning if you want me to.
And has your complete application then been submitted at this point as well?
Complete application has been submitted. As a matter of fact, the only revision that I made was when we originally submitted the application, there was a strike through on the 24/7 requirement. That's been resubmitted to my president and my medical director. I'm just waiting on the email saying that they signed it digitally, and I'm going to send it to Bill.
Great, thank you very much.
Not a problem.
Beautiful. Thank you, George.
No problem. Thank you very much.
Okay, moving along for adjuncts that are added to local agencies and establishments. The applications were received in the office and brought here for final approval. We have Habitat for Humanity in Dutchess County is becoming a pad site. Town of Wallkill EMS is adding on CPAP. Town of Newburgh EMS is adding on 12 lead EKG. West Hurley Fire is adding on glucometry. Clayco, which is a company, is adding a pad site. Watchtower EMS is adding Narcan. And West Hurley Fire Department is adding albuterol. I just want to bring these forward, and if we could have a verbal, all those in favor?
Aye.
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 Okay, with no opposing parts there, we will move on. Thank you, everybody. So next is the evaluation subcommittee report. Dr. Ashad, I know you joined us. Are you unmuted?
Thank you. We had one case for review, and essentially it was from one of our community squads that had forwarded a case, and there was no specific complaint regarding it aside from there were other quality issues related to the provider, and they wanted us to review a cardiac arrest call for completeness and protocol adherence and just general medical response. So not to get too detailed into the case, it was not overly complex. It was an elderly gentleman with cardiac arrest. Law enforcement was first on scene. ACLS care was initiated and all around seemed to be appropriate. There were some issues related to the timeline and the documentation in regards to, certain medications were given, before the IV access was established in regards to the chart. There were some medications that were given after the, per the timeline after the patient had been transferred to the ED care. But overall, there's no significant issues regarding the documentation or the overall care. So we're simply going to just refer this back to the case and recommend they do a higher, somewhere along the order of 25 to 50% QA review of all this particular provider's ALS calls, and give specific and tactical feedback on how to improve documentation. Because I think that's a challenge for many of us, not one provider in particular. And there's certainly some elements to take away from that.
Great. Thank you, Akshan. So I think, and that was I saw that email this morning. I think why they were putting it forward was just they wanted to make sure we were seeing what his follow-up care was doing. And that's fine. But I think that's why they brought it forward to us. Okay. Thank you so much, Dr. Rashad. DOH enforcement notifications. I don't have them, Bill. Do you have them?
Unfortunately, I do.
You should just send them to me each time and I'll go through them and read them.
Okay. So Kevin McKeon out of Lynbrook, New York, was suspended for 1 year effective 10/22. Suspension was stayed and placed on probation for 3 years, effective 10/22 of this year, and assessed a civil penalty of $2,000 for violations of Part 800, Section 16A and Section 11. Giovanni Gattier out of Flushing, New York, was revoked effective 11/22/21 and assessed a civil penalty for $2,000 for violations of Part 800, 16A and 4. Center for Allied Health Education was assessed a civil penalty of $2,000 for violations of 10 New York State Code 66.3. I'm not exactly sure what that is. Christopher Howland was suspended for 1 year effective 10/18/21. The suspension was stayed pending no further violations for 3 years. Assessed a civil penalty of $2,000 for violations of Part 800, 16A and 5. Christine Correa out of Brooklyn was suspended for 1 year effective 10/13. The suspension is stayed pending no further violations in 3 years. Assessed a civil penalty of $2,000 for violations of Part 800, 16A, 4, and 9. Eric Gessler out of Scotia, New York, was suspended for 1 year effective 9/16/21. The suspension is stayed pending no further violations for 3 years. A civil penalty of $2,000 for violations of Part 800, 16A and 5. Timothy Leach from Blue Mountain Lake, New York, was suspended for 3 years, effective 9/17/21. The suspension is stayed pending compliance with probation. Placed on probation for 3 years, effective 9/17/21. Assessed a civil penalty of $2,000. $1,500 is stayed pending the compliance with the stipulation and the order for violations of Part 800, 16A, 2, and 9. Thomas Warrington out of Blue Mountain Lake was revoked on 9/13/21, assessed a civil penalty for $2,000. $1,000 is suspended pending compliance of payment for violation of Part 815A3 and Part 816A1. That's it.
Okay, great, thank you. Helicopter committee report. Dr. Larson and Dr. Stumiller, please.
Good morning. So the committee met this morning, and two items of discussion of interest to the REMAC. The first was regarding stroke patients for which the helicopter is called. With the discussions and passing last month of the updates to guidelines for stroke for the REMAC, in that if you have a patient with a suspected large vessel occlusion that's more than 30 minutes from a comprehensive stroke center, to take them to a more local center. We just discussed that in those cases, air ambulance might be available to transport the patient to that thrombectomy center, comprehensive stroke centers. Currently, there is Vassar Brothers is a thrombectomy center, and Westchester and Albany are comprehensive centers. And so we just wanted to start that concept that it is available, if it's available, an air ambulance may be able to get that stroke patient to a thrombectomy or comprehensive stroke center. And then that dovetailed to the request from the region to update the hospital capabilities. And we are going to identify whether Hackensack University Medical Center in northern New Jersey might be one of those thrombectomy or comprehensive centers for stroke patients in the southern service area for the air ambulances, and in the southern area of the region. And so we request and remind everyone to please update those hospital capabilities for the region.
Yeah, that's really important, and it's a thing where it's kind of like this dynamic document that needs to be updated and kept, you know, really clear of what each center can do, so that we make sure that it's out there.
This will also give the region an opportunity to update the Muru application, which is the application that most providers carry on their phones, that have all the collaborative protocols, the standard BLS protocols, and a lot of the regional policies and procedures. We're working with them right now, going through everything to make sure that everything that they have is updated. And we did notice that there are some of the hospital information isn't, so we'd like to get that out to all our providers. Thank you.
Okay, great. Thank you, David. Dr. Larson, Eric, do you have something for RTAC? Are you on mute, Dr. Larson, or did you have to drop off? Okay, we'll table that for right now. Move along to quality improvement reports. Jeff, please.
The schematron update that took place on 1 October is once again caused problems with Zoll. We are working with Zoll as well as with the State Department of Data and Informatics. Hopefully we'll see resolution of this. We have a number of PCRs that are outstanding because of this. They will be uploaded as an historical update. And also having some issues with ESO. They are aware of the issue. They are working to fix it. Work continues on that. We have created a regional performance dashboard. You can find that link on our website right off the main menu. I have both 2020 and 2021 data for several categories. Opportunity to take a look at the number of calls, hours that the calls were, the time frame that they were in, a fair amount of information that's available there. And that's about it.
All right, thank you, Jeff. Protocol committee, Michael.
Thank you. Just an update with regards to the RSI program. We continue to look at that, and that work is underway. There was a new discussion that we had, which is probably applicable to this group with regards to the ET3 discussion. Richard Brandt was at the state meetings in the Innovations Committee and made an announcement that effective November of 2021, Medicaid would be allowing agencies that are non-ET3 certified to seek funding for Medicaid patients being transported to alternate destinations, alternative destinations. As a requirement for that, there needs to be regional protocol where there are facilities that are identified as alternate destination facilities. So we had a preliminary discussion on it. Bill's going to be reaching out to the other program executives, and Bob Zelli is going to be reaching out to Dr. Cushman with regards to the collaborative protocols to see if there's going to be a statewide initiative to have a set of protocols across the state. So I don't know, Bill, if you want to comment any more on that at this point.
No, that I have reached out to all of the executive directors of the other regions, and I did get a response from New York City, who has a fairly extensive program in ET3. So, I mean, it's a pretty good outline, and I think there's some good stuff that we can use in there. Most of the responses I've gotten we don't have anything in place yet. And they are also looking towards the collaborative group to see if they are going to come up with some kind of a generic or a collaborative protocol that we can use.
So I know one of our brief discussions that we had was that, potentially these places would need to be 24-hour operations. And I don't know if there's any of those that exist in the state, but then certainly open it up to the docs for any other comments or things that they want the group to look at.
Well, that's what I was just going to ask you. Is this, alternative destination decision like an urgent care? Is that what you mean? That would be.
Yes, that's what they mean.
Yeah.
But you can, in like an ET3 like program, you can have the urgent care, but you can also have a treatment in place piece to take care of like the middle of the night. It can be like a combined program, but you do have to have an option 24/7.
So I don't know of any urgent cares that are 24 hours, right?
The only one, David Violante, is the Dutchess County Stabilization Center. Is that a 24-hour operation?
Yeah.
Or Dr. Papish?
I was gonna say, that's the only one I know of. It's not a medical care, but for psychological care, they're open.
And that would be one of the centers that folks could transport to.
And what's it called? It's a stabilization center?
Yeah, it was came out of DISRIP. It's a, sort of the grand vision was that it would be a 24/7 sort of psychiatric care, psychological care station for patients. But the psychiatric component is gone, and there's no medical real resources other than social workers and some psychological referrals. But they had wanted from their start to be an alternative destination.
That actually would be very helpful for the region for sure. And what about if they did psych telehealth? Have they thought about doing psych telehealth in there? Because you could get psychiatrists on telehealth very easy. And it's the only specialty that you don't have to touch a patient. They make their decisions upon the way the patient looks, how they comport themselves, what's around them, what's their appearance, and how do they interact with you. So it is a very viable option.
Except you have to pay the psychiatrists. I think there were some resource issues.
Oh, did the district funds end or?
Yeah, that's when it kind of downgraded the services that they had available like a year or two ago. But I mean, they're still receiving patients currently as walk-ins from the police, drive-ins, and the patients that actually need emergent intervention, they're referring up to us. So they are seeing some volume.
Okay. Interesting concept, something that could work, to be honest.
Yeah.
Anything else, Mike?
Oh, that's all I have. Thank you.
Okay. That brings us to new business. We already had Port Jervis speak, Anything else that anyone wants to add under new business? Not hearing anything. I'm going to move along. CMAC report. So we met the first time that some people have been in person. We did have a part of the contingency meet in person. The rest of us met on Boardable for a video option distance. So I had to do it through Boardable, but it was a good turnout. The meetings went a little bit longer than I think they thought, and I don't know if it was because of just the amount of discussion. We had a lot of discussion around the protocols. We had some revisions, mostly out of New York City, which brought up the point of our last protocol revisions we submitted from the collaborative still were not signed off. So again, that brought in the discussion of how this is all working, and with the change in elected officials, that we move forward, and we made a recommendation that we do develop a medical director position for the Bureau, just because we feel like it would be a helpful addition to the team. Nothing was really moved on it, but we did discuss it. There was, again, like I said, they asked us about some of the older programs, our supraglottic airway being one. And I could not attend the second day. I don't know if any of you, if David, do you want to talk about the training education and really what happened the second day?
Yeah, we had quite a bit going on. Actually, Jeff was there too, weren't you, Jeff?
Yes, Jeff was
yeah.
definitely, I saw him in the minutes
Right.
on one.
Yeah. As far as the supraglottic airway one, I did speak with Ryan about that specifically, and he double checked with Valerie to make sure that it was for sure on the commissioner's desk, and it was. And they're just not sure what the holdup is. I guess there's a few things that way. He wanted me to check in with him after a couple of weeks just to follow up, so I'll continue to do that. In terms of education, there's a few different changes here and there, nothing of huge impact to us, I don't think. At this particular point, it's a lot of sort of how the operations work for training facilities and centers. They're trying to recognize that, during COVID, while there's a lot of good online work, most programs suffer if it's completely online, and so things shouldn't be totally online. And so they're looking at a 50% of total online work for things. But aside from that, I don't think there was anything else huge training and ed wise.
Yeah, a couple policy statements that came out, right? So the EMT time, like it doesn't have to be observation in a hospital anymore.
Oh,
It's
yeah.
10,
Right.
right? So it's 10 encounters now. They could do it in a doctor's office, urgent care, on an ambulance. So the state recognizing during COVID, it's hard to get into the hospitals, that, more options for students to be able to get those patient encounters that they need. There was some discussion about a 60-40 CIC split to allow, newer CICs or to work with veteran CICs, that doesn't have to be the same person for everything. The state was supportive of that. As far as the executive order goes, cards will not be extended for a year. The way it's written, it says it gives the Bureau the option as needed or as determined necessary, and they have determined that it's not necessary at this point to extend cards for another year. So they have the option still, but right now it's not being done. I think those were kind of the big things from training and ed, and then it was added to the agenda for next time that training and ed is going to start looking at the AEMT curriculum. I don't think I missed anything, Dave. I think that's it.
No, that was it. I just didn't want to, it's definitely not boring the group. I just didn't want to drag it on too much further, but honestly, that piece about the patient encounter is a really good piece and a big piece. And there was a lot of good discussion about that. And it could be in a lot of places where you can get your patient encounter. So that's really good.
Yep. And then the only thing at SEMSCO was that they also supported the idea of a New York State EMS physician medical director that reports directly to the commissioner, and CMEC and SEMSCO jointly are going to send a letter to the commissioner recommending that be created.
Yeah, we've been talking about that for years, and they've always pushed back. But I really think from a perspective of knowing priorities, knowing what we need to get done. And we couch that with how their, referendums and emergency release of protocols and such during the pandemic were so late that, they were ineffective. They came out when, things were better. So it was a perfect segue of why we brought it up of, this is where we should have a hands-on medical person right there, directing and keeping control of these things. Because, it was so ineffective. And
Yep.
I'm not faulting anybody, but a doctor wouldn't let that happen. We would keep on it. We would stay with it. We would make sure it was timely and that it kept up to any changes, because things were so fluid at that point. Things were
Yep.
changing left and right. So it just
Yep.
makes sense. And I made a motion for them to make it Dr. Daly. So
Yeah, well, someone else wanted to make an motion that it couldn't be anyone who was from New York City. So there was a lot of ideas as to
I
to who
forgot.
it should be, but it's the idea would be to have a voice for EMS in the commissioner's ear that could uniquely speak to the perspective of EMS, because as we saw during the pandemic, a lot of these things were either late or didn't get enacted or weren't understood correctly. And same thing with the protocol approvals.
Yeah, and I think that, who's the best leader? The best leader has consultants around them, surrounds them with people that are, respected and really professionals in their field that are able to supply you with the information. You need to have that team surround you as you're, really to consult with you and to advise you. And, that's why it makes this so important. Hopefully it's not going to fall on deaf ears. No pun intended. Okay. Anything else? We have open forum now. If anybody has anything they wanted to bring up to the committee while we're all here, I kind of zoomed through that agenda. It's only 10:11, but that's okay.
Hey, Pam, I just got a quick thing.
Sure.
Yeah, did you guys talk about Mike's report at State Council yet?
No.
So I really like to recognize Mike Beninati. He did.
Wait a minute. Wait a
Yes.
minute. Oh, I know what you're talking about.
It was outstanding.
Yeah,
Yeah.
so this is what I was thinking. Shoot, thank you, David. Michael, I would like you to forward that report to every person on the committee. Because I think that the docs who don't get to go to CMAC and SEMSCO would benefit from this. And I make a motion now that you forward that report on to all the committee members, please.
Second.
Thank you. All right, David, go ahead. Sorry, you reminded me of it. I didn't write it down.
No, it was an amazing report that everybody needed to hear. It was very cogent about the state of affairs in healthcare overall, not just EMS, and the effects from when somebody calls 911 to when they go home, and just the whole effects of the system. And it's things we've been talking about for years. And I don't know, Mike, hopefully this is not a segue to retirement where you're like, that's it. I'm saying my piece and I'm leaving it at the door. But, you really put it out there of where some of the challenges are. And it's everything we've talked about in Dutchess County and the reports at the region and the regional conferences and reports and things that we've done. And it was super fantastic. So they created a special tag, and Mike is going to be chairing it, and has a bunch of support from around the state already to create a white paper and all that jazz. And I know that Mike won't talk about himself this way. And so it was just a super, really good job by him. And it really represents the Hudson Valley well. And hopefully we can get some good traction and work on making EMS better for everybody. So good job, Mike.
Well, I had said to him, as soon as I read it, I said, so Mike, let's get this published. And he's like, nobody's going to want to read that. And I go, yes, they will. You absolutely could get that published because it has the context of a much broader audience. So yeah, Mike, I hope since you are sitting there in front of your computer, you're sending it to all the committee members right now, I hope. And thank you, David. I had that in my mind. I didn't write it down. You know how that is.
Well, Pam, since I'm a man, I can only do one thing at a time. So I'm concentrating on the meeting. But when I get off the meeting, then I'll send it to Karen and ask her to distribute it.
Yeah, but then I'll give it to a woman to do. Okay, thank you, Michael. Yeah, I just encourage everybody on the committee, if you can hear me, please read this. It's so well said. I started a master's in healthcare administration program just about a month ago now. And one of the courses I'm taking is this course called Population Health. And Pop Health is really kind of like what you're talking about in there, Mike, is an organization of doctors trying to improve our healthcare because it's broken. Basically, our healthcare system is broken. And so they're trying to come up with creative ways that we can work around, change things, try to do things in such a way to improve health in this country. If you look at it, we spend way more of our GDP on health care dollars, and we are like 8, 9 down the list in terms of outcomes. Just horrible compared to how much money we spend. So this is really a forum going forward that's on everybody's mind. And, you know, the COVID proved it to us even more so that we need to improve the way we deliver healthcare, the way our system works. And really, everybody should have healthcare. It's kind of crazy. But thank you, Michael. It was excellent. Anything else? Any comments, any concerns? I appreciate everybody coming this morning. We're still going to stay in a electronic video fashion form going forward. Our next meeting, when's our next meeting, Bill?
Well, that was one of the things I want to mention. We're scheduled right now for January 3rd, which is before the open law meeting extension for video it ends. So we're not sure what's going to happen after January, but we are good for video up until the January meeting.
Okay.
Then we have another meeting scheduled for March 7th. This is the tentative meetings for 2022. And we have one for June 13th, but I'm a little concerned about that. I believe that there's a holiday on the 13th of June, and then September 12th and November 7th. So those are the 5 meetings that we have scheduled, but we can look at that June 13th if somebody gets back to me and see if it is a holiday. It would.
So let's send out the list, because Karen would usually send out the list, and then people can get back to her if there's any issues or concerns. But let's send out the list in a attachment to everybody this morning so that they can have it and look at it.
Okay, we'll do that. So at this point in time, we're looking at January 3rd.
January 3rd, that's cool. Okay.
Okay.
Anything else? Otherwise, I will ask for a motion to adjourn. Rapid speed meeting this morning.
Motion to adjourn.
Thank you. You really listened to me. I appreciate it. Is that a second?
Yeah, second, Stu Miller.
Thank you, David. All right, everybody, have a great day. Thank you so much.
Bye.
Bye.